Episode 38, Exertional Chest Pain in a Professional Athlete. Welcome to Sports Medicine Case Studies, where I review published case studies, discuss key takeaways, and provide some practice questions. Today's case, a 35-year-old male professional athlete first presented to a tertiary emergency department with exertional chest pain. He reported 3 prior episodes initially described as sharp in quality, but later becoming dull. The pain was accompanied by exertional dyspnea. On physical examinations, the authors report the only abnormal findings were a systemic hypertension with a blood pressure of 143/89 and resting sinus bradycardia. He had no personal medical history and no family history of premature coronary artery disease. He was a lifelong non-smoker. In the ER, his 12-lead electrocardiogram performed during this episode demonstrated biphasic T-wave inversion in leads V2 and V3 with inferior early repolarization pattern. The patient's high-sensitivity cardiac troponin level was initially normal and was also normal 2 hours after presentation. Given the patient was asymptomatic at rest with non-ischemic EKG changes and negative serial troponins, the athlete was discharged with an outpatient cardiology follow-up organized and anticipation of a functional exercise stress test. So my differential for this, number 1, hypertrophic cardiomyopathy, number 2, coronary anomalies, number 3, coronary artery disease, and number 4, myocarditis, which is always on the differential for chest pain in a young athlete, although in the absence of a systemic illness makes this diagnosis less likely. And other non-cardiac causes would include exercise-induced bronchospasm and just general musculoskeletal chest pain. I'd like to recognize the authors. This case was recently published in the Journal of the American College of Cardiology Case Reports by Dababneh and colleagues out of the Gold Coast University Hospital in Queensland, Australia. I am Scott Hall, a primary care sports medicine physician, and I am studying for my sports medicine certification in 2026, and I hope you'll join me on the journey. This podcast is for educational purposes only. Okay, additional testing was pursued as an outpatient on this athlete. A resting echocardiogram was described as normal, with left ventricular ejection fraction of 59%, no regional wall motion abnormalities, no valvular or structural abnormalities were identified. He then underwent an accelerated Bruce protocol stress echocardiogram. The test was symptomatically strongly positive. It had to be terminated at only 70% of predicted heart rate maximum, which was 130 beats per minute and 10 METs, because of severe central sharp chest pain. On echo, there was appropriate augmentation of left ventricular systolic function and no new regional wall motion abnormalities were observed. Given this discordance between the subjective complaint and the objective findings, the team ordered a coronary CT angiogram. The CT showed a left dominant circulation and an anomalous right coronary artery arising from the left coronary sinus. The vessel had multiple high-risk anatomic features, including an acute takeoff angle of less than 45 degrees, a tangential course, an intramural segment within the tunica media of the aortic wall, and an elliptical luminal vessel shape. One finding that makes this case unique is the anomalous right coronary artery also gave rise to the sinoatrial nodal branch. In this athlete's left dominant system, this non-dominant right coronary artery's primary clinical significance was its supply to the sinoatrial node. The case was discussed at a multidisciplinary heart team meeting, and the consensus was to pursue further ischemia testing. A dobutamine stress echocardiogram was selected for its higher sensitivity. Despite the use of high-dose dobutamine, maximal atropine, and adjunctive hand grip and leg exercise, the study achieved only a 77% predicted heart rate maximum on this patient. Additionally, this patient again experienced severe chest pain during the exercise portion of the stress test. Once again, no new regional wall motion abnormalities developed. The team recognized marked chronotrophic incompetence, or the inability to augment heart rate despite maximal pharmacologic and physical stimulation, and the authors identified this incompetence as an ischemic equivalent. The anomalous right coronary artery supplied the SA nodal branch, and flow limitation through the anomalous vessel during stress was compromising perfusion to the SA node. This prevented appropriate heart rate augmentation with exercise. The authors note this is a rare but physiologically elegant demonstration of what they describe as matching territory of ischemia. In other words, the anatomy explains the physiology. Because the SA node was ischemic, that demonstrated why the heart rate would not accelerate as expected with exercise. Over the following weeks, the patient's symptoms worsened. The frequency and severity of his angina increased with progressive exercise intolerance, leading him to cease all physical activity. He was referred for invasive coronary angiography, which confirmed a non-dominant anomalous right coronary artery arising from a separate ostium in the left coronary cusp. The case was rediscussed at the multidisciplinary meeting, and despite the vessel being non-dominant, the team concluded there was compelling evidence of clinical and physiological ischemia manifested as SA node dysfunction. Surgery was recommended. The surgical team proceeded with an isolated right internal mammary artery graft to the acute marginal branch. At 4 months post-surgery, the patient was completely asymptomatic, and repeat exercise stress echocardiogram demonstrated a marked improvement in chronotrophic response. He achieved 81% of his predicted maximum heart rate at 13.5 METs without chest pain or EKG changes. This test was terminated electively because of leg cramping. Several key takeaways. An anomalous right coronary artery from the left sinus of Valsalva is the most common coronary artery anomaly overall, with a prevalence of approximately 0.1 to 0.3% in the general population. It carries a lower risk of sudden cardiac death compared with anomalous left coronary artery from the right sinus. CT coronary angiography is the gold standard for anatomic delineation. Current guidelines both in the United States and in Europe recommend it as the initial imaging modality when an anomalous coronary artery is suspected or incidentally found. It provides spatial resolution needed to identify high-risk features including vessel shape, acute takeoff angle, intramural course, and the relationship to surrounding structures. I want to comment on the 2025 American Heart Association and American College of Cardiology scientific statement on anomalous aortic origin of coronary arteries. For competitive athletes with an intra-arterial right anomalous coronary artery, athletes should be assessed for symptoms suggestive of myocardial ischemia and undergo provocative stress testing. It is reasonable to temporarily withhold or limit competitive sports during initial evaluation. Surgical intervention may be considered if there is evidence of inducible ischemia or symptoms suggestive of ischemia. For athletes with no symptoms, no inducible ischemia, and no complex ventricular arrhythmias, competitive sports participation is reasonable with shared decision-making and longitudinal surveillance. After surgical repair, return to competitive sports can proceed after complete sternal healing and testing showing no evidence of ischemia and no complex ventricular arrhythmias. This represents a key distinction from intra-arterial left anomalous coronary arteries, where surgical intervention is recommended regardless of symptoms or stress test results before competitive sports participation. Okay, a couple of questions for you. Number one, a 22-year-old male collegiate soccer player is found to have an anomalous left coronary artery arising from the right sinus of Valsalva with an intra-arterial course on CT angiography. This was performed after an episode of exertional syncope. Stress echocardiography showed no inducible wall motion abnormalities. Which of the following is the most appropriate next step in management? A. Refer for surgical intervention before competitive sports regardless of stress test results. B. Clear the athlete for full competitive sports participation given the negative stress test. C. Restrict to low-intensity sports only and repeat stress testing in 6 months. D. Start beta blocker therapy and allow return to competitive sports with annual surveillance. E. Obtain a cardiac MRI. And if no fibrosis is present, clear for sports participation. Correct answer is A. According to the most recent American Heart Association and American Cardiology scientific statement on competitive sports participation published in 2025, competitive athletes with intra-arterial anomalous left coronary artery from the right sinus should be considered for surgical intervention regardless of initial clinical presentation or the results of ischemic assessment, given the high-risk anatomy. Athletes should not participate in competitive sports if left unrepaired. This differs from the management of the anomalous right coronary artery, like the case we discussed, where sports participation may be reasonable in the absence of symptoms or inducible ischemia. A negative stress test does not preclude sudden cardiac death events in patients with an anomalous coronary artery, as noted in both the 2018 and 2025 American Heart Association and American College of Cardiology guidelines. Okay, question 2. A 19-year-old female competitive swimmer undergoes echocardiography for a murmur evaluation, which incidentally reveals a coronary artery anomaly. Subsequent CT coronary angiography demonstrates an anomalous right coronary artery arising from the left sinus of Valsalva with an intra-arterial course. She is completely asymptomatic and has never had exertional symptoms. Exercise-stressed echocardiography shows no inducible ischemia and no ventricular arrhythmias. Which of the following is the most appropriate recommendation regarding competitive sports participation? A. She must undergo surgical repair before any return to competitive sports. B. Competitive sports participation is reasonable with shared decision-making and longitudinal clinical surveillance. C. She should be permanently restricted from all competitive sports. D. She should undergo invasive coronary angiography with fractional flow reserved before any decision is made. E. She may return to sports only after cardiac MRI excludes myocardial fibrosis. The correct answer is B. The 2025 AHA-ACC scientific statement states that for competitive athletes with an intra-arterial right anomalous coronary artery and no evidence of inducible myocardial ischemia and no complex ventricular arrhythmias, competitive sports participation is reasonable with shared decision-making and longitudinal clinical surveillance. The key distinction from the intra-arterial left anomalous coronary artery, where surgical intervention is recommended regardless of symptoms or stress test results. Okay, question 3. Anomalous coronary arteries are the second most common structural cause of sudden cardiac death in competitive athletes in the United States. Which of the following statements regarding the epidemiology and pathophysiology of anomalous aortic origin of coronary arteries is correct? A. Anomalous left coronary artery from the right sinus is the most common coronary anomaly overall. B. Sudden cardiac death from coronary anomalies occurs equally during exercise and at rest. C. Anomalous right coronary artery from the left sinus is the most common coronary anomaly overall, but anomalous left coronary artery from the right sinus is more prevalent among athletes who die suddenly. D. A normal exercise stress EKG reliably excludes the risk of sudden cardiac death in patients with anomalous coronary arteries. And E. Myocardial bridging of the left anterior descending artery carries a higher risk of sudden cardiac death than intra-arterial anomalous coronary arteries. The correct answer is C. The most common anomalous origin is the right coronary artery from the left sinus of Valsalva, but among athletes who die suddenly, anomalous origin of the left main or left anterior descending coronary artery from the right sinus is far more prevalent. Sudden cardiac deaths from coronary anomalies most commonly occur during or shortly after exercise, though rare cases at rest have been reported. A normal stress EKG does not reliably exclude sudden cardiac death risk. The 2018 and 2025 AHA-ACC guidelines explicitly note that some patients have had sudden cardiac death despite a normal stress EKG. Myocardial bridging is generally incidental and clinically insignificant and does not require further risk stratification before competitive sports participation in asymptomatic athletes. Question 4. A 28-year-old male professional rugby player presents with recurrent exertional chest pain and dyspnea. CT coronary angiography reveals an anomalous right coronary artery from the left sinus with an acute takeoff angle, a slit-like ostium, and an intramural course within the aortic wall. Which of the following imaging modalities is recommended by current guidelines as the preferred type of stress testing to assess for ischemia in this patient? A. vasodilator or adenosine stress cardiac MRI, B, pharmacologic nuclear perfusion imaging, C, exercise or dobutamine stress testing with echocardiographic, nuclear or MR imaging, D, resting transthoracic echocardiography with strain analysis, E, coronary artery calcium scoring. The correct answer is C. The current guidelines published by the American College of Cardiology and American Heart Association and European guidelines recommend non-pharmacologic functional imaging, specifically exercise or dobutamine stress testing with echocardiographic, nuclear or MR imaging to assess for ischemia in patients with anomalous coronary arteries. Exercise or dobutamine stress testing is preferred over vasodilator stress testing because it better reflects the dynamic conditions with increased cardiac output and aortic wall tension under which ischemia occurs in anomalous coronary arteries. Vasodilator stress testing does not reproduce the hemodynamic conditions that cause flow limitation in anomalous coronary arteries and is therefore less appropriate. Thank you.